RayHub is RaySearch's in-booth dedicated space for learning and leading together. So come on down if you're interested in hearing about upright particle therapy. Today we have the topic from plan to proof, and we're going to be hearing from Erik, Traneus, Senior Research Scientist at RaySearch Laboratories, Stephen Towe, CEO, Leo Cancer Care, Christina Vallgren, CEO and co-founder Terapet, and Professor Dr. Alexandru Dasu from Scandion Clinic and Uppsala University. So we have a lot of interesting content coming your way. I want to say, if you have any questions at any point, just raise your hand or shout out. I can come to you with a microphone. And I just want to say, come a bit closer so you can hear us. There's comfy seats down the front. Come on in so you can actually hear the content. But with that said, I'll hand over to you, Christina.
Okay. Good afternoon, everyone. My name is Christina. I'm the CEO of Terapet. So it's a Swiss-based medtech startup. So we are developing novel nuclear imaging solutions for medical applications. So today it's my great pleasure to share the stage with the three great partners and friends of Terapet. So together we are going to give you a first look at a very exciting collaborations we are developing jointly. So combining imaging, adaptive treatment planning, and the clinical implementations for the next generation particle therapy. So I will start with giving you one key idea, precision. In Switzerland, we have these great famous stories about William Tell. He was asked to shoot an apple on the head of his son with a crossbow. So this has become a symbol for Switzerland's precision, accuracy, and trust under stress. So in many ways, particle therapy faces similar challenges. So we are aiming at a target we can actually not see, but at the same time protecting the healthy tissues around it. So the question is, how can we truly know during the treatment the dose is really delivered in where it's supposed to go? So this is the challenge Terapet is addressing. So at Terapet, we have developed the Qualyscan, a next generation in-beam PET verification that we can really measure the real-time beam verification inside the patients. So our philosophy is very simple. So we measure, we plan, we measure, and verify. So we make sure that the proton beam is going to where it's supposed to go. Why is it important? Because anatomic changes, patient moves, and even very small uncertainty can influence the quality of treatment. So, but we are not only providing imaging. We are connecting the image with smart, intelligent feedback, treatment planning, adaptation, and to fit in the real clinical environment. So our device, we are aiming, our focus is to aim on very compact detector integration, very compatibility with clinical workflow, and also the next step for the in vivo dosimetry for the next proton therapy. I just want to show you a short video of our first product that has already been implemented and tested at the Scandion Clinic here in Sweden. So this device has been installed and tested at the Scandion Clinic, and Professor Dasu is going to give you more details on the results. So enjoy the film.
What if you could see what happens inside the target during particle therapy and track how the beam spreads and triggers nuclear reactions? Conventional particle therapy employs extensive machine QA to manage error sources in the beam, gantry, couch, and imaging systems, followed by patient QA to simulate and predict dose delivery to the target. Yet, closing the gap between these predictions and what's
So this device we are already offering as a part of our product offering. So if you are interested, so it's a Qualyscan QA device.
Inside the target during particle treatment.
So we can measure any type of fountains with the beam on and off, also post the treatment.
In a chosen phantom. After treatment, Qualyscan moves in to capture the signal generated by the particle beam before it fades away. This results in the highest possible PET image quality appropriate for model validation and constancy checks. The acquired PET image can be analyzed by comparing...
Then at Terapet, we develop both the hardware and the software so that we integrate it, hopefully in the very near future, that will be a part of the RaySearch adaptive treatment planning system.
These insights allow rapid confirmation of delivery accuracy and help identify areas requiring further investigation. A CT scan can be registered with the PET data, mapping measured...
We can import any type of DICOM file, so to compare with the planned and the treated
unintended
irradiation.
The PET image can also be exported in DICOM format, enabling seamless collaboration and interchange with third-party or in-house software, so you can build on the analysis and tailor the results to your specific needs. Qualyscan supports any type of phantom, giving you the flexibility to...
So we support any type of phantom, so give the flexibility to the adaptation in different treatment angles as well.
Any treatment plan in any phantom. Check constancy, validate models, and find new ways to make particle therapy safer and more precise with Qualyscan.
Okay, thank you so much. So obviously, so hardware is not enough, so the image must be connected directly to intelligence of treatment planning as well. So that's why today's collaboration is so exciting, so that we are really going to implement the adaptive treatment planning and with the clinical verification in real clinical environment. So I will leave the floor to Erik. I leave the floor to you. Thank you.
Hello, hello. All right. Hi, everyone. So I'm Erik from RaySearch. So I will speak a little bit about where we are with the PET range verification and what we have done historically. So here is a line of time. And we start up here. This is about 10 years ago. So these red boxes here are things... Our time in points in time where we have worked with PET range verification. So it's all started here with a pencil beam algorithm to predict positron yield. And then we took a step into Monte Carlo, and now we're here starting up the collaboration with Terapet and Leo Cancer Care about online range verification. I will do a few dive into this a little bit. So this is the pencil beam algorithm. It's from Katja Parodi and others. This is a paper which is now more than 10 years old. We implemented this in RayStation. It's essentially taking the pencil beam dose engine, and instead of painting out NAD or dose, we paint out beta yield production and feed that into RayStation. And you can look at the screen on a measured PET, predicted PET, and a planned dose, and put those on top of each other and look at profiles, etc. This implementation, which is now 10 years old, has been used at a clinic in China. This is a SWIC proton carbon facility in Shanghai. They have used it over 10 years actually, and use it primarily for breast patients. And one application, this is from a recent paper, is to see how verify that the range is computed correct in cases where you have metallic clips somewhere in the chest wall. And this is a typical, actually quite good clinical application of PET-based range verification. And I should say all of this in RayStation is for research use or retrospective plan analysis, so nothing of this is in a clinical release yet. Now, this was pencil beam. Here we take a big leap forward to the Monte Carlo dose engine. So we have now a beta yield scorer in RayStation. So you can predict beta yield from these reaction channels. It's the same channels and same cross sections etc. as we had in the pencil beam. And of course now it's Monte Carlo, everything is super fast. So this is the time it takes to compute the dose, and to compute the beta yield is about the same time. It doesn't slow things down. First application of this was actually in our version of RayStation for small animal use for preclinical research. So what you see here is in fact not a human patient, it's actually a mouse. Here is the mouse. And what you see here is dose and also prediction of positron yield in this mouse irradiated by a fairly low energy proton beam, and with a beta yield predicted with the Monte Carlo code. So this is a so-called Sirmio beamline from the group of Katja Parode in Munich. So next step is to bring this into the vicinity of the Leo chair, and of course with the detector from Terapet. And what we're doing now is starting up this on a new baseline in the research version of RayStation, also adapting it to the Qualyscan system and looking into delivery timing, which is essential here because there is a decay of beta, of course, that you have to account for, and do this for IBA machines, maybe on fit, also for the SWIC. And also another application of this is specifically for flash, because for flash you deliver those in maybe hundreds of milliseconds, which means that other diagnostic techniques have difficulties coping with a very, very high energy deposition rate, whereas a PET-based transfer verification doesn't have that problem at all. You can take any dose rate in principle, and that gives you an imprint of the beta yield, or the dose that gives you the beta yield, and the detection itself, of course, happens after the irradiation over a time, which duration you can choose yourself, which means that there's no issues with high dose rate, etc., when it comes to doing QA for flash. So by that, I hand over to Alexandru from Skandion.
So, does it work? Oh, it works. My name is Alexandru. I'm a professor at Uppsala University, and also I'm a research and development coordinator at Scandion. And I'm going to tell you about how we have used the detector from Terapet for some experiments aiming to see what is its clinical potential. So what we have done is we have created a plan for a phantom. We have not yet tried on a patient, but on a phantom. And then we have subjected that phantom to a clinical workflow where the phantom has been imaged with the cone density has positioned right, and then we have delivered the proton plan, and then we have attempted to look at the distribution of induced activity to correlate that with the dose distribution. Now, how we have used that, or we plan to use that, one idea would be, as Erik has said, to compare the predicted activity distribution from the treatment planning system with the measured dose distribution, and from that to try to see how well we have delivered the dose, the intended dose, in order to ensure that we have verified that the irradiated volume corresponds to the target volume. We have also tried to see what will happen if we induce a shift in the phantom positioning, and we have been able to see a simulated setup misalignment, and we have seen that the activity distribution that we measure was considerably different from the condition when we had perfect positioning. Then the other one, the other idea we have is to take one reference image and then several subsequent images of the induced activity, and do that to see whether there are any changes, for example, in the patient anatomy that will lead to a different activity distribution. And then, of course, with that, we have been able to image a simulated, for example, morphological change in the anatomy of the patient. And from that, we are now trying to see how much we could use this type of information, on one hand, for example, to trigger an adaptive process, and also how early we could see it, what are the magnitudes of morphological changes that we could image with that. So setup, and then this one is from the shift, and you see here the shift in activity. Is that? No. You see here the shift in activity that shows that indeed, if you have a change in the anatomy of the patient, you could see a shift in the activity, which it's a sign that something in the anatomy of the patient has changed. With that, I'm passing on the microphone. Please. Oh.
Thank you very much, and thank you very much, Christina, for inviting us to be a part of this. We're very pleased to be working with the team from Terapet, the team from RaySearch as well. So I think, you know, when we look at this and we look at this as one advancement amongst many, the inclusion of PET imaging, proton radiography, upright MR, lots of different imaging modalities, we can see the benefit of them. And it's super exciting to see where the field of particle therapy is going. But it kind of then begs the question of why aren't these things standard of care, and where does LEO come in, and what value do we bring to this partnership? And it's really on simplification. So the simpler we can make the underlying architecture, it's the easier it is to get fantastic technologies and research out of academic institutions into the clinic and turned into products. So moving away from or supplementing the idea of having these large rotating gantries that are very difficult, even upgrades on centers that have got to end of life can be 40, 50 million to go and upgrade those centers, never mind with new technology. Going and simplifying the architecture to a fixed beam makes these kind of partnerships a lot easier. And this kind of idea of simplification spans the entire industry as we see it. And as Leo Cancer Care's role in the industry and having fixed beams, it is to bring a simplified architecture that enables innovation. And this is just one fantastic example of it. But if we look at things like MR Linacs, it's an amazing technology platform. But in the pursuit of adding diagnostic quality MR and all the benefits it brought, having spent time at Elekta, it was a real challenge to get over things like VMAT, which I know they're there now. And the idea of doing MR-guided protons would be a very, very complex one indeed. The same when it comes to proton therapy. There's no doubt about it that proton beams offer massive clinical advantage. They really do. But in the pursuit of bringing the benefits of protons and being in a position where we say we're not going to compromise on beam, it must be the best quality beam, we have to then sacrifice also on delivery techniques. And I can see the IBA team, you guys know how challenging it's been, right? To go and develop arc therapy for protons. Really, really difficult to modulate and change the magnets per energy, per gantry angle. Super complicated. And adding diagnostic quality imaging at the isocenter, also really complicated to do. Never mind thinking about adding MR or PET or any of those other things. And the same when it comes to beam delivery angles. The idea with a CyberKnife is an amazing product. But the idea of delivering from all of the different angles brings some complexity with it as well. So simplification is where we think we can really add to the industry and bring technology into the clinic faster. So having the upright platform, this is again one example of it, but being able to go and say there's no sacrifice on imaging. We can now work with institutions to come and look at things like MR guidance, at optical imaging, at PET imaging at the isocenter with a fixed beam. So much easier to enter into those research projects. When we think about proton beams, the upright technology in fixed beams now is being used across carbon ion, protons, photons, flash, electrons, all of these different new novel beams, again, much easier to implement. And then from the point of view of delivery methods, having a fixed beam and rotating the patient, completely decoupling radiation delivery from rotation makes all of that easier as well. So with that, we're going to end it today with kind of a first look at what implementation might look like for this technology in the Leo Cancer Care architecture. I don't know, Christina, did you want to talk through this if there's no sound? Okay. So you can see the Leo platform here, patient positioning, imaging with the imaging system on show here at the Leo booth. You can see how that works, but now we're really talking about taking the Terapet technology into that fixed beam architecture, mounting those panels also alongside the existing technology, just to bring that additional imaging information. And this really for us, a first step into implementation of this technology. We're working as always very closely with the team from RaySearch, but it truly is a demonstration of that ability to take idea, to take research, take concepts, and take them forward into products far faster than we've ever seen before. And that is what is so exciting to us about the fixed beam technology. Yes, it can do amazing things today, but it's really about where we are taking the industry with fantastic partners alongside us. And with that, I'll let the rest of this play, but thank you very much all for joining us today.
Thank you everyone for joining us. I hope the speakers will stay around for a few minutes if anyone has any questions.